Welcome back to the Cambridge Neuroscience Interdisciplinary Seminar Series. This series features current work from neuroscientists across the schools and departments of the University of Cambridge, reflecting the pioneering work and diverse interests of our members here. Each seminar focuses on one of the new interdisciplinary themes of Cambridge Neuroscience, and for more info on the talks covered in this seminar series and all things neuro-related here at Cambridge, please follow us on Twitter at CamNeuro and follow the links below. Okay, so good afternoon, everybody, and welcome to the final seminar in this term's Cambridge Neuroscience Interdisciplinary Seminar Series. We're delighted to welcome you all, especially those who have joined us from outside of Cambridge. Today, in the special seminar, we're delighted to welcome Dr. Tim Dalgleish. Tim is a clinical psychologist and he is a program leader at the MRC Cognition and Brain Sciences Unit, also a practitioner for the NHS. His research focuses on understanding and developing psychological treatments for common mental health problems, such as depression and anxiety. And of course, what he's going to talk to us today, post-traumatic stress. So his kind of niche is that he adopts translational approaches, seeking to utilize insights from this basic cognitive neuroscience to enhance clinical interventions. So with that, I'm going to pass you over to Tim, and thank you very much for joining us.
Thank you very much for that lovely introduction, Davia. And it's great to be here. So I've worked on many different things in my career, probably too many, but certainly working with young people who've been exposed to trauma and trying to help them in their darkest hours sometimes deal with life-changing experiences has been without doubt one of the most rewarding as well as one of the most challenging. And even though your paths only cross normally for a few months, the interactions you have with these young people can live with you for decades. And I started working in this area right at the beginning of my career in the late 1980s, and the work continues today. So when I was thinking about what to talk about today, I thought I'd actually just start right back at the beginning and then walk through the journey from the clinic where it started to the scientific studies to understand what was going on when young people experienced traumas, to the development of treatments and interventions and evaluating them, and then through that right back to the clinic again. So it's really a story of clinical translation from insights to experiments to treatments and so on. So it all began when I was a clinical psychology trainee at the Institute of Psychiatry in the late 1980s, working with Professor Bill Yule, and he was my supervisor. And at that time, there were a number of major disasters that had occurred, and we were seeing the children and young people who'd been in these disasters and trying to understand what had happened to them and to try to help them. So the first of these was the Herald of Free Enterprise ferry sinking in 1987. So this was a completely different world back then. We didn't really understand much about trauma in children. Margaret Thatcher was the Prime Minister, and back then we thought she was probably the worst Prime Minister we could ever have. So little did we know what was going to be coming down the line. There were pound notes. Wimbledon, I think, won the FA Cup. Cliff Richard was top of the charts at Christmas. A completely different universe. So we saw lots of the young kids who were on this ferry sinking. And then there was another sinking of a pleasure boat, a sort of party boat in the Thames a couple of years later. And then before that, there was the King's Cross fire in London. And then a cruise ship went down in Greece, which had a lot of school kids on a school cruise. So all of the young people from these different disasters started passing through the clinic we were working in. And we had no idea really about post-traumatic stress in children and young people then. It had only been introduced as a diagnosis, post-traumatic stress disorder, in 1980 into the diagnostic manuals. And really that came from the Vietnam War and was really directed at adults and, and things like combat trauma. So this was a completely new world to us. We know a lot more about this now, of course, and we now know that up to 70% of young people, by the time they get to their teenage years, have experienced what we would consider a significant trauma. And a lot of those young people develop post-traumatic stress disorder. And although this can be quite large number of, a large percentage of young people early on in the first few months, it does go down, but remains a problem right up to 4, 5, 6 years later, with as many as 20 or 30% of young people still meeting the criteria. So as you probably know, post-traumatic stress disorder is a psychiatric diagnosis. And in adults, and we'll come a bit more to how it might be a bit different in children later, it's characterized by 4 sets of symptoms. So re-experiencing the trauma in various ways through nightmares or flashbacks or intrusive pictures or thoughts about what happened. And those re-experiences are very distressing and scary and horrible. Trying to avoid things that would cause such re-experiencing, so trying not to think about what happened, trying not to talk about what happened, trying to avoid reminders, and in some cases becoming completely cut off, socially withdrawn, and emotionally numb, or even having complete amnesia for the experiences that you've had. And then changes in the way you think and cognitions. So thinking that it's all your fault, you're permanently damaged, you'll never be the same again, your life has been ruined. Why is the world such an awful place? Why did this happen to me? And persistent thinking along those lines. And finally, really being in a constant state of sort of red alert. So hyper aroused, always on edge, always looking out for danger, sleeping badly, poor concentration, being very irritable, being jumpy, and those kinds of things. So this constellation of symptoms really characterizes someone who's had one of these experiences and is really struggling to get on with their lives. So out of these encounters with all these amazing young people who we saw back in the 1980s, we came up with a kind of research plan of what we wanted to do, because no one had really worked in this area. And our first thing was to think about, well, what would a theoretical model of how these young people are experiencing trauma and why some people go on to have these horrible symptoms and reactions while other people are actually completely fine. What's going on? What's our theoretical view of how that fits together? And the second is to then use that theory to do a series of experimental medicine or cross-sectional studies to try and elucidate what the mechanisms are which we theorize might be important and how they relate to symptoms. And then take those mechanisms and say, well, are those mechanisms driving the development of post-traumatic stress over time? So if they're really important mechanisms, they should be able to predict who's going to develop problems and who's not going to be able to develop problems based on whether those mechanisms are active or less active. And then we can think about treatments that correct those dysfunctional mechanisms, if you like, and we can do clinical trials, randomized controlled trials to evaluate those treatments and see if they help these young people with post-traumatic stress to feel better. And then we can think about how we might implement those treatments, if they work, into the health service. And this is a well-trodden framework developed by the MRC called the Framework for Developing and Evaluating Complex Interventions. So it's a long process. So when we set this out back in the 80s, we thought, well, this is at least 2 or 3 years work. And here we are, whatever, 35 years later, and we still haven't got to the bottom of this pipeline. So it's a very, very long process to understand what's happening, develop treatments, evaluate them, and try to move them into policy. So what I'm going to do is talk about some of this journey in a kind of whistle-stop tour today. So in terms of the theory, if you've got the appetite, there's some extremely long-winded and quite hard work papers. This one in the middle, which took me about 2 years to write, I don't really recommend it to anyone, but a special prize go to anyone who's read it or is willing to read it. But it really sets out quite complex theoretical ideas about why some people develop post-traumatic stress, what the mechanisms are, and how we might think about treatments that can correct those mechanisms. And a lot of this work was inspired by David Clark here on the left and Anke Ehlers, and their theories down on the bottom there. And David was my supervisor when I was an undergraduate, And now if I wanted an hour of David's time, I'd probably have to wait about 2 years. But then I used to see him for an hour every week, and I never realized how lucky I was to get so much support and help from someone who's so very wise. So big thanks to them. But we can really distill all these complex theoretical papers, these hundreds of pages, I think, into things which we call, when we're working with these young people, the 3 M's. And the first of these is the nature of the trauma memory that is kind of stuck in people's heads. And what we find is these memories are very often sensorily laden. They're very distressing. They're very disjointed. People can often smell what they smelt at the time. They can hear noises. So it's a very sensory, visceral, fragmented memory of what happens. It's not a sort of neat verbal account that we tend to have about our lives when we've practiced telling our stories and telling our narratives over time. So these memories are kind of almost frozen in time. The second is the meanings that are projected onto people's experience. So what does it mean that this happened to me? What does it mean about the world? What does it mean about the people in the world, if often there's other people involved in these traumas? What does it mean about me because I reacted in a particular way, or I'm still really struggling with the consequences of what happened? So memories and then meanings. And then the management. How do people try and cope with these things? And I've already alluded to some of the symptoms. Sometimes people completely shut themselves off. They try very hard to avoid any reminders. Sometimes people cope, if they're older, teenagers and adults, through drinking and drugs. There's all sorts of different coping mechanisms, many of which are actually maladaptive. So they bring some short-term relief, but actually in the long run, they're not going to get you back on the straight and narrow. So our view is that these 3 M's are absolutely critical. There's other mechanisms that we've looked at, but these 3 are consistently important, and they're the basis of what we want to target when we develop our interventions. So part of the process then was, having got a theory, identified the key mechanisms, we wanted to do some experimental and cross-sectional studies to try and see if those mechanisms are actually important, or if they're just what you might think of as epiphenomena. Well, you might find that people have these kind of thoughts or these memories, but actually those aren't the things that are driving their post-traumatic stress over time. So having a theory that these things are important, and then showing that they're really present in people who've got these problems and that they're driving things over time, were the next 2 things we wanted to try and do. And this is work with 2 of my great colleagues, Richard Miser-Stedman, who's professor at UEA, and Patrick Smith, who's a professor at the Institute of Psychiatry now. And we've been working together for many decades on these problems. So starting with the first M then, the trauma memory. So we've done many studies on this, but I'll just tell you about one, which is where we asked young people to talk about the traumatic event they'd experienced. And then we asked them to talk about another negative, a really unpleasant, the other worst thing that they had happened to them that was different to their trauma. And the traumas ranged from violent assaults, family problems, accidents, road accidents, animal attacks. So these are all sort of 8 to 18-year-olds. So a whole range of different types of trauma, some of them interpersonal, some of them not. And we asked them to write these narratives down, and in some cases they just told us the story, and we would transcribe them. And then we went through these narratives of the unpleasant event and of the trauma, and tried to look at how disjointed and fragmented and incoherent they were by looking using sort of grammatical coding systems which allow you to quantify how disorganized a narrative is. And what we found is that, and this is young people in the first 2 to 4 weeks after a traumatic event, where they all met criteria for something called acute stress disorder, which is what this ASD is. So in the graph on the left, you can see that we've got the degree of memory incoherence for the trauma memories versus the unpleasant memories. For those young people who have been in a trauma and then have all these symptoms of post-traumatic stress. And you can see that the level of incoherence is far greater in the trauma memories than it is in the comparable unpleasant memories. But in the young people who've had exactly the same types of trauma, these are the two bars on the right, they've also had the same types of trauma, but they don't have any symptoms of post-traumatic stress. So these are the people who, despite having these experiences, are actually feeling fine. Their memories are actually comparably coherent for the trauma memory and the unpleasant memory. So this gave us some confidence in our view that something about the way the memories are organized in those who end up with PTSD or acute stress disorder is very, very different than those who've had the same kinds of experiences but actually go on to be completely okay. So the next thing we looked at was meanings. And again, we did a whole bunch of studies on this. And I've already talked about these. These are the kind of thoughts that we come across time and time again when we're working clinically with young people. What does it mean that this has happened to me? And what does it mean that I've not been able to get over it, that I'm really struggling? I might not be able to go to school. I might not be able to leave my house. I'm continually worried about what's going to happen. And they often have thoughts like, I'm going crazy. I'll never be the same again. I can't trust anyone. Nowhere's safe. The world's an evil place. I'm doomed. My whole life is ruined. So quite powerful thoughts, which, as you can imagine, just drive their distress on a day-to-day basis. So we did a similar kind of study. Young people who've been involved in a trauma and those with who meet these criteria for PTSD have all those symptoms I talked about before, compared to those who've had exactly the same experiences. We match them very carefully, but don't have PTSD. And their scores on this measure called the CPTCI, which is really just a measure of how many of these kind of thoughts that they tell you they've had in the last 2 weeks. So when you ask them about these thoughts using this standardized measure, which we developed, you see that they're much more frequent in those who have PTSD. And this is also true for the other subscales. So there's 2 subscales. For example, the one on the right, FPSW, is fragile person in a scary world. So that's thoughts about the individual. I'll never be the same again. I'm always in danger. People will always take advantage of me. People will always hurt me. Whereas the first subscale is more about the world itself. The world's a dangerous place. No one can be trusted, and so on. And on both these subscales, the scores are much, much higher in the young people who have PTSD. So again, this gave us lots of encouragement of our view that the memories are different in the young people who end up getting PTSD, and the kinds of things they're thinking all the time are also very, very different, as we predicted. And in fact, we've done some more work where we use a statistical technique called network analysis, where we link these kinds of thoughts into ratings of the different symptoms of PTSD. And you look at how these different things drive each other in these associations in a network of interacting symptoms and cognitions. And we found that these particular thoughts are very highly interrelated with the different symptoms of PTSD. And I can talk more about this analysis and what we found later, if you like. So we've talked about memories, we've talked about meanings. As I said earlier, there's other mechanisms and other cognitive processes that are in our theories and that are relevant, but we don't think they're as central as these ones. But just to give you an example, we've done work on memory biases, attention biases, judgments, hypervigilance. So all these other cognitive processes which support mental health problems, if you like. In other words, if you're already distressed, your whole mind starts to operate as if the world's a distressing place. So you selectively remember distressing things, you selectively attend to distressing things in the world. Your decision-making errs on the conservative side because of that distress. And we've done lots of research mapping out this whole range of different cognitive components, which are very, very different in individuals with PTSD who are sort of aged 8 to 18 compared to those who aren't. But I won't go into the details of those. So these things are, of course, all very interesting, but they're basically just associations. So they tell us that if you get a young person who's had a horrible event and they've developed these horrible symptoms, then they're more likely to have a disorganized, incoherent kind of narrative story about what happened. they're much more likely to have these kind of really self-detrimental thoughts going through their head all of the time. They'll have a bunch of other cognitive biases that are driving the way they navigate the world cognitively on a day-to-day basis. But it doesn't mean, as I said before, that those things are actually driving their PTSD. They could just be by the way phenomena that go along with the PTSD. So what you need to do next is these prospective longitudinal studies. So this is where you measure these things very, very soon after a trauma, and you see if they predict who's going to go on to develop problems or the maintenance of problems, in particular young people over time. So these longitudinal studies allow you to attribute a bit more causality to these mechanisms, as opposed to just showing that they're correlated with the clinical difficulties that you're interested in. So we did a whole bunch of these prospective longitudinal studies, and they tend to always take the same format. We would work with our colleagues in accident and emergency rooms. Young people would come in, and we'd see them within a few weeks of a trauma that had caused them to go to the A&E, and we'd measure all our different mechanisms that we're interested in, the coherence of their memories, the types of thoughts they're having, and then we'd follow them up over 3 months and 6 months and see if the young people who were high on those measures were indeed the ones who later on developed problems and needed help. And this was a test, really, that those mechanisms are actually the key drivers, key causal drivers of the evolution of post-traumatic stress over time. So all the studies are more or less the same, and the key findings were that these dysfunctional appraisals, these thoughts about the world and the self, the sensory laden memories, and various types of maladaptive coping, which I haven't really talked about too much, they all predicted who was going to get PTSD 6 months later, over and above the initial symptoms. So it's not like they're just more related to symptoms and therefore they predict it. Even if you control for the initial symptom severity, these processes seem to be driving the evolution of PTSD across time. And this isn't the case for what I would call the usual suspects in PTSD research, which we get from the adult literature. So if you work with adults, the things that drive who's going to get PTSD are things like the severity of the trauma. Did you end up in hospital? Did you end up with broken bones? Are you female? Have you got a psychiatric history? So many of them broad vulnerability factors that you find in a lot of mental health problems in adults. In young people, none of these factors seem to be involved in predicting who's going to get PTSD. It's all driven by the kinds of thoughts, the nature of the memories, and the way young people try to cope with those things, and not the things that you would expect to find in adults. And there's sort of 4 different trajectories we found from these studies. One is persistent, so lots of symptoms almost immediately after the trauma, and these symptoms just persist unabated for months and months, and often would persist for years. Then there's what we call the resilient trajectory, which is almost no symptoms to begin with and continuing absence of symptoms. So young people who seem to take these traumatic events in their stride, despite the traumas objectively being just as severe as those who end up with difficulties. And then there's a recovered trajectory, which is quite common. So an initial period of symptoms which abates after 2, 3, 4 months, and then young people are generally fine. And then a much rarer delayed expression. So young people who are fine for a while and then develop post-traumatic stress, often because there's another much milder trigger a bit down the line. So I've tried to sort of capture those here. So you get these acute PTSD reactions, which then abate after a few months. It's chronic PTSD, which goes on for a really long time. And then this delayed onset, which is much rarer, which kicks in about 6 months later. So we felt like we got somewhere. We developed a theory. We'd shown that the things that we'd theorized about, the 3 M's, the memories, the meanings, and the maladaptive coping strategies, were all associated in these experimental studies with young people who ended up with PTSD. And then we did a lot of longitudinal studies to show that if you measure those things early on, it's actually those things that predict who ends up getting the disorder later, suggesting that they're causally involved in the evolution of problems. So the next thing is, well, can we develop a treatment that targets those things and tries to change them and reverse them? And if they are really the things driving the problems, that should lead to symptom relief and remission of PTSD in these children and young people. So that's what we focused on next. So our treatment targets the R3Ms, the nature of the trauma memories. Can we rebuild those memories so they're not disjointed and incoherent? The nature of the meanings, can we challenge those meanings, introduce new information so they get shifted and molded? And the maladaptive coping mechanisms, the management, can we introduce new coping mechanisms that are more functional and adaptive? And Patrick, one of my colleagues who I mentioned earlier, wrote this fantastic treatment manual, CBT with children, adolescents and families, which really encapsulates these views. So our first trial of this treatment, so we developed the treatment, it lasts about 12 sessions, and lots of back and forth to try and get it right, lots of input from families and from older children and teenagers in what works and what didn't work in terms of engagement and so on. And then we were ready to take it to our first clinical trial. And in our first trial, we just compared it to a waitlist control. So we did a randomized design. We got a small number of people, about 20 in each group. 20 of them were randomly put on a waiting list, and 20 of them were given our new treatment, focusing on our 3Ms. And then, of course, those who are on the waiting list got the treatment at the end of the waiting period. So everyone got treated in the end. And it was an extremely effective intervention. So this is about 15 years ago now. So you can see on this graph that TFCT is trauma-focused cognitive therapy, the new intervention. And the other line is the wait list. And the scores on the left are CPSS scores. So that's essentially a measure of PTSD symptoms. So you can see before the trial, the pre-time point, both groups of young people, 20 in each group, had almost identical level of symptoms, which were actually very high and very severe. But at the end of the trial, the waiting list hadn't really changed, but the young people we'd seen with our therapy, the symptoms are almost completely gone. And then we followed those young people up 6 months later. We didn't see them again, so this is just 6 months down the line, and the symptoms remained absent. So this was way better than we could possibly have anticipated. So a very strong intervention effect. And this gave us real belief that targeting these 3Ms is really critical for what we're trying to do. Sorry. For the next trial, we thought we'd move earlier. So the one I've just talked about was young people who'd had PTSD for at least 6 months. So they're in this kind of chronic PTSD group. So, but what we wanted is can we actually work with people a bit earlier? So the first 3 months, as I said, there's a trajectory where people have some distress, young people struggle a bit, but then they spontaneously get better. So we didn't really want to do anything in the first 3 months, but also we didn't really want to wait till 6 months because that's quite a long time. And in fact, that was the minimum. And in our first trial I just described, some of the young people had had PTSD for 2, 3, 4 years. So we wondered, is there an early intervention we can develop that we can do at 3 months post-trauma, recruiting people who've been into A&E, and then looking for the ones who at 3 months haven't got any better, that persistent symptom group that I talked about before. And then for those ones, is there something we can offer them? So our next trial was aimed at this acute window of symptoms, 3 to 6 months. And again, we got very, very similar results. This time, instead of a waiting list, we did what's called treatment as usual. That's the TAU you see there. So this is what the young people would have been offered in the NHS as it stands. But of course, because we're developing these treatments for the first time, there is no intervention in the NHS that they get offered. So they do sometimes get a bit of help and they have someone to talk to, but there's certainly no intervention targeted at their PTSD. And again, you see at the pre-trial phase, the symptoms are more or less the same. And again, these radical improvements with the therapy, which persist this time over a year. So we did a longer follow-up. This is a bigger trial. Whereas again, treatment as usual, a little bit of improvement, but again, nothing like what we're seeing with the treatment. And all the young people who had treatment as usual, the reason you don't see them going beyond the post is that we then offered them the intervention at that point. So again, great encouragement that not only is this treatment helpful, it's also useful in this very early acute phase. One thing we did in all these trials, and I'll just give you a flavour of that, is keep in mind our key mechanisms. So we wanted to not only show that an intervention that focuses on memories, meanings, and management factors, our 3 M's, was actually helpful. We wanted to measure those things through treatment and see if they got better, and the amount that those mechanisms changed drove the amount of improvement following the therapy, because that gives us another way of feeling reassured that the therapy is working by changing those mechanisms. So just to give you an example, here's an analysis from the first trial. So we know that whether or not you get cognitive therapy for PTSD, this box on the left, or you're on this waiting list, is a really strong determinant of whether you get PTSD reduction or remission at the end of post-treatment, or whether your symptoms stay the same. But the question we had is, well, is that working by changing the meanings that young people ascribe to the trauma? So we're targeting those meanings in the therapy, but are we actually changing them? And are those changes driving the intervention? And you can obviously do this with a mediation analysis. So as I said, we know that effect's very strong and significant. But we also know that whether you get the intervention or not really has a bearing on whether these meanings change. In the wait list, they don't change at all, but they change radically if you get the therapy. And that the amount that they're changing is really determining your symptoms at the end of treatment. And once you put that indirect path into your regression analyses, the relationship between treatment and PTSD is much reduced. And this gives you a very strong bootstrapped mediation effect. So strong evidence that the treatment is working by changing our 3 M's. This is obviously just one of the M's, meanings, but it was also true for memories and management. So developing a theory, testing it through different experiments, looking at causality through longitudinal studies, and then evaluating it in a trial. So I'm going to talk briefly now for the last 5 minutes about PTSD in very young children. So all of this work was in 8 to 18-year-olds. And actually, there was this sort of myth when we were doing this work that very young children didn't get PTSD at all. And here's one of our early studies where we looked at PTSD criteria, which are in the DSM-4. And these criteria are all developed for adults, and they're just down-aged, if you like, applied to young people. And these are young people who've been in car accidents or violent assaults. And we found that if you're 10 to 16 years old, using these adult criteria, about 12.5% of young people end up with PTSD. But if you look at the 2 to 6-year-olds, virtually none of them end up with PTSD with these criteria. But then there was a work emerging from the States and from our own work suggesting that it's ridiculous to apply these very adult or older child criteria for PTSD to very young children, because PTSD manifests itself in a completely different way in these very small kids. And so what you need is a whole different algorithm, if you like, for understanding PTSD, where you look at disrupted play, reverse developmental milestones, bedwetting, all sorts of things that you might see in young children, which wouldn't be manifest in, say, a 14-year-old, and certainly not in an adult. And once you develop a different algorithm which tries to capture the real essence of PTSD in this younger age group, suddenly you see that the prevalence of PTSD, this is with this thing DSM-AA, alternative algorithm, goes up to almost the same levels as you'd find with older children. So this suggests that what we need is a completely different set of diagnostic criteria when we're thinking about PTSD in this very, very young age group. And since then, we've done a meta-analysis of various prevalence studies around the world using these criteria. And I won't talk you through the forest plot in detail, but it shows at the bottom where you can see that black lozenge that around 20% of young people in this preschool under 6 years old age group end up with post-traumatic stress disorder. And this is from a variety of trauma. And if you look at the list of studies there, you see that some of them say PTSD AA, that's this new algorithm that's developmentally sensitive. And some say DSM-4, that's the old adult algorithm. And you can see that the ones from the DSM-4, the prevalence levels are very low, and in some cases, essentially next to zero. So this new algorithm has been quite revolutionary in allowing us to discover the nature and the prevalence of distress in this very young age group. We also looked at the Child and Young People's National Survey, which is carried out every few years, and it's driven by postcodes, so it's a completely representative sample of thousands of young people in the UK, where they do full diagnostic analyses to see what the prevalence rates of all kinds of clinical problems might be. And what we wanted to do with these data is ask the same question. Well, if we look at PTSD with the old adult version of PTSD, which is the standard, versus our new alternative algorithm, which is developmentally sensitive, do we detect different numbers of young people in different age groups with PTSD? And what we found was that not only in this very young age group on the left, where you can see the proportions of young people who we detected with PTSD with the new algorithm, which is this PTSD-YC thing, the darker color, versus the old algorithm, which is the DSM, the lighter color. In the 5 to 6 year olds and the 7 to 8 year olds, we didn't detect any children of these 18,000 who met criteria for PTSD using the old adult criteria. So in the survey, which came out, in fact, it was actually up to 10 years, no child under 10 met criteria for PTSD with the standard PTSD criteria in the literature. But when we applied these young child criteria, you can see that these darker bars, that there were 3, 4, 5%. And this is the whole population, not just young people who've experienced a trauma. So there was really high levels of PTSD in the population that had previously gone undetected. And even for the older children, where these older criteria, these adult criteria should be more applicable, we more than doubled the number of young people we were able to detect with clinical level problems right up to the age of 14 or 15. And it was only really in the 15, 16-year-olds that these developmentally adjusted criteria weren't really delivering much change. So it's really important lesson here is that when you're trying to understand PTSD, not just in very young children, but even children up to the age of 12, 13, 14, you have to adjust the algorithm. You can't just downage the adult algorithm as people have been doing for many years. So this is just the general population. We did a similar survey for looked after children with a smaller data set. And there we can find that even up to the age of 18, this young person's algorithm identifies way more than doubles the number of young people you find. And look at these rates, over 50, sometimes nearly 60% of children who are in care, looked after children, have a full diagnosis of PTSD once you do this developmentally appropriate criteria. This was one of the most shocking findings I've seen in all of my time working in this area. 50, 60% of young children with really significant diagnostic levels of distress. I won't talk too much about that. So can we adapt our treatment that we've had so much success with in older youth for working with these very young children? So we put a lot of time in trying to do this because we were very skeptical. The treatment's very what you might call cognitive. You know, the average 3-year-old isn't really infused with many maladaptive meanings, thinking about the nature of existence. Is this very cognitive treatment which tries to change trauma memories, tries to look at the meanings of the trauma for young people and maladaptive coping mechanisms, is it really going to be of any use for 3, 4, 5, 6-year-olds? So this was the question we wanted to answer. And we used the same structure of the treatment, 12 sessions, as we did before, but the delivery was radically different. So instead of the kind of verbal delivery, so for example, if you're a 15-year-old, we might rework the memories using a narrative on an iPad where we use different colors and we rebuild the memories in a collaborative way. You can't do that with a 2, 3, 4-year-old. So we used lots of drawing, where this is a 3-year-old's drawing of a road accident where their mum had been trapped under the car and ended up really badly injured and, you know, whisked off in an ambulance. They'd almost never been separated from their mum before in this kind of way. So lots of drawing rather than narratives, and trying to change the memories and the meanings through drawing, and also lots of Playmobil. And what's remarkable is in the whole Playmobil range, you can get pretty much something for every trauma you can imagine a child might experience. You can get whole hospitals, nurses. You can even get the Grim Reaper in Playmobil, which we were rather alarmed to discover. So one of the best things about this project was going to the toy shop with a large work checkbook and buying huge amounts of Playmobil. And it's a very fun intervention to deliver, notwithstanding the fact that these are traumatized kids, because they're actually able to express what happened, and you're able to rebuild the memories, understand the meanings by just these completely different mechanisms of interaction. So again, we did another trial like we did before, and these are our data on PTSD. So following our CBT, our new intervention, 78.5, so nearly 80% of the 3 to 8-year-olds in the trial who had PTSD at the beginning didn't have PTSD anymore. So we managed to get almost every kid better. Whereas again, treatment as usual, this is usual NHS care on the right, only 6 or 7% of those young kids lost their PTSD diagnosis. So nearly all of them, the PTSD persisted. So again, the treatment was incredibly powerful and very, very encouraging. And of course, after a trauma, it's not just PTSD that young people experience, all sorts of other symptoms. And we found similar good effects for our treatment on fear and anxiety and on feelings of depression in these very small children. So just to summarize them, I've tried to tell a whistle-stop story of a translational program of work that started longer ago than I care to remember, looking at young victims of trauma, to try to illustrate what translational science looks like. You start with insights in the clinic, people come in, you don't really understand what's going on, you talk to them, you develop a theory, and then you try and understand if these mechanisms you've identified are actually really powerful and driving it. Then you develop a treatment to target those mechanisms and you evaluate it in trials. And I'm glad to say that we have finally got to the point where our interventions are adopted within NICE guidelines for PTSD, and the new algorithm for diagnosing very young children is now in the DSM-5 as PTSD for infants and preschoolers. So eventually you get to change policy and you get to change the diagnostic manuals, but it's a very long haul. So I think there's compelling evidence to focus on these 3 M's. There's compelling evidence that even in the very youngest children, as long as you're sufficiently careful and take a developmentally sensitive approach, that you can really make a difference in understanding what's going on and in treating it. And these different trials on the right, I haven't talked about Prospects and Decrypt, which are actually in children who have had multiple traumas, often abuse and violence, so much more complex traumas, but the treatment's very, very similar. And we've just finished the Decrypt trial. And our final trial.Optic I haven't talked about, which is for teenagers, where we've made it an app-based intervention with little and often intervention from the therapist, which teenagers much prefer than, sitting down with someone for an hour in a room. So all of this work I think is really promising, and it's been a complete privilege to do it. Just a last shout out to my colleagues, ones I mentioned already, but a whole group of others, and to our funders. Thank you very much.
Thank you, Tim. A very poignant seminar. And indeed, thank you to all of the speakers that featured this term. What a lineup. Join us next term with some new faces. And first up, we welcome Professor Amy Milton. Amy is a university professor in behavioural neuroscience in the Department of Psychology at the University of Cambridge and director of the Cambridge MIND, which is Memories in Neuropsychiatric Disorders Lab. Her research focuses on the neurochemical and molecular mechanisms underlying memory reconsolidation and their exploitation to develop new treatments for mental health disorders. She also has a strong interest in the development of translationally relevant models of mental health disorders and facilitating dialogue between basic and clinical neuroscientists working in mental health. Amy will be talking to us about targeting maladaptive emotional memories to treat mental health disorders and giving us insights from rodent models. For more info on the talks covered in this seminar series and all things neuro-related here in Cambridge, please follow us on Twitter at CamNeuro and follow the links below. See you next time.